Hello everyone. My name is Dr. Senthil Narayanan, Senior Resident Ortho. Today I'm going to talk about ACL reconstruction. So, uh, the ACL reconstruction, ACL is the most common, more than half of knee injuries. There are like 4 lakh ACL reconstructions are being done in here. Coming to demographics, it's most common in female athletes. So the ratio is 4 is to 5 is to 1. So ACL, as you know, there are two parts of ACL. One is anteromedial fibers, and the other one is posterolateral fibers. So anteromedial fibers are taut in flexion, and it provides stability in the anterior-posterior direction, prevents anterior translation of tibia, and posterolateral fibers are tight in extension, and it provides rotational stability. So the causes of ACL injuries include non-contact sports. There's like valgus momentum of the knee, and there is anterior translation of tibia, and there is a contact injury, hit on the lateral aspect of the knee, and there is indirect injury, direct contact on the lateral aspect of the knee. It can lead to ACL injuries. It's more common in females because females have an altered biomechanics in the knee. It's a bit different from they have increased Q angle and all those such things. So coming to the steps of ACL reconstruction, there's 4 main steps. The first one is graft selection. The second one is creation of femoral tunnel. The third one is creation of tibial tunnel. The fourth one is graft fixation using endo button or interference tools. There are many types of grafts. There are many techniques of creation of femoral tunnel, tibial tunnel. Graft fixation also can be done by many things. So these are most common that is being followed recently like everywhere or all those things. The next is important thing is tunnel positioning. Tunnel positioning has to be proper, appropriate, or else it leads to the failure of the surgery. Patient will have constant pain. They may develop complication. The graft may go for re-rupture due to increased stress due to improper positioning of the graft and many other such things. Because these patients are usually sports persons or young patients who require anatomical reconstruction of their knee. So if there's any slight difference in all those things, it will lead to the complications. So coming to tunnel positioning, for the right knee, that is the 10 o'clock position for the ACL. And for the left knee, it's a 2 o'clock position. As anybody the clock like the 10 o'clock and 2 o'clock position is single bundle technique. So there's like single bundle technique, double bundle technique, and all such things. The most accurate landmarks for arthroscopic ACL reconstruction is the native ACL movement. Where the native ACL is present, you exactly put the graft in the same area where you can see the footprint of an ACL, native ACL. We put the graft in the same footprint. So next is the important thing is the resident ridge or lateral intercondylar ridge. It's the lateral intercondylar ridge is the one that demarcates the anterior edge of the ACL. The anterior edge is being identified by the lateral intercondylar ridge. The bifurcate ridge separates the anteromedial and posterolateral bundle attachment. So putting a scope, you can find this lateral intercondylar ridge and bifurcate ridge. So you will know which bundle you can differentiate those bundles. So this is the picture that is being distal femur. It's in the sagittal cut. You can see there's a this is the lateral intercondylar ridge. It's been marked and it just shows the anterior border of the ACL. And this is the bifurcate ridge. This bifurcate ridge separates the anteromedial bundle and posterolateral bundle. So this is the anteromedial bundle forms a comma-like crescent shape over the anterior aspect of the posterolateral bundle. So this is the resident ridge or lateral intercondylar ridge. As you can see, there's the anteromedial bundles differentiated from posterolateral bundle by bifurcate ridge. So two things important, that is lateral intercondylar ridge and the other one is bifurcate ridge. So this is the image showing that ACL ligaments, as you can see in this specimen, this anterior, this anteromedial bundle and posterolateral bundle, as you can see in extension, extension and 90 degrees of flexion. In extension, the posterolateral bundle is taut. In flexion, the anteromedial bundle is taut. So anteromedial bundle gives the anteroposterior stability, posterolateral bundle gives the rotational stability. So this is the lateral, this is a CT image of the same picture. You can see the lateral intercondylar ridge and the lateral bifurcate ridge, anteromedial bundle and posterolateral bundle, and is attached to the lateral intercondylar tendons. Lateral intercondylar tubercle and medial intercondylar tubercle. It's attached like just in front of the tibial spine. So this is a screw home mechanism. Screw home mechanism is seen in the knee to prevent the support the quadriceps action. Just because it's called the external rotation of tibia on the femur during extension, and internal rotation of tibia on the knee during flexion. There is external rotation of tibia on extension, and there is internal rotation of tibia on flexion. Because the medial tibial plateau articular surface is longer than the lateral tibial plateau. So to accommodate that medial tibial plateau articular, medial femoral condyle, to accommodate that medial tibial plateau articular surface, it just rotates, internally rotates the tibia during knee flexion, and externally rotates the tibia during knee extension. So locked knee decreases the work performed by the quadriceps while standing. So coming to harvesting the hamstring graft. So incision made approximately 3 finger breadths distal to the medial joint line and 2 finger breadths medial to the tibial tubercle. Rib stitch the ends of each tendon. So they take the semitendinous and gracilis, which can be identified. Once you make an incision, first you see the sartorius fascia. You go beneath the fascia, you can see the semitendinous and gracilis. So all these sartorius, semitendinous, and gracilis are called pes anserine. So you take that graft with graft harvester, you release the graft, and with the rib stitch, you stitch the ends of each tendon. Release adhesions until the tendons have a good recoil. When tension is applied, you use the tendon stripper to harvest the tendons, and they keep the knee flexed while harvesting to protect the saphenous nerve, which runs in close contact with the graft as near the adductor tubercle. So the incision is approximately 3 finger breadths middle of the medial joint line and 2 finger breadths medial to the tibial tubercle. After graft, you take the graft, you prepare all those, release all those adhesions, loose muscle fibers and everything, and you release the applied tension and you stitch it there with stitch. So portals, there are 2 portals, that one is anterolateral portal and one is anteromedial portal. Anterolateral portal is used as a primary viewing portal. Anteromedial portal is used as the primary instrumentation portal. You insert the scope in the anterolateral portal and insert the instruments and all those cannulas to work. It's a working portal. Anteromedial portal is a working portal, anterolateral portal is a viewing portal. So once you inserted the scope, so there are 2 scopes, 30-degree scope, 70-degree scope. 30-degree scope for ACL reconstruction, 70-degree scope is used for PCL reconstruction. So order of visualizing includes knee in extension. So first you see the suprapatellar pouch, any pathology in the suprapatellar pouch, any loose bodies and all those things. Then the patellofemoral joint, you inspect any cartilage destruction or erosion, and you inspect the lateral gutter and medial gutter. So knee in extension, first is suprapatellar pouch, then patellofemoral joint, then lateral gutter and medial gutter. And coming to knee flexion, first you see the medial compartment, intercondylar notch. Intercondylar notch, you can see the ACL and PCL, whether they are intact or whether they have been damaged. You can inspect with a probe. Then knee is put in the figure of 4 position. You can see the lateral compartment, lateral meniscus, lateral femoral condyle, lateral distal condyle. You can see the meniscus, any injuries there, and all those things. So what is cyclops lesion? Cyclops lesion is a fibroproliferative tissue that blocks extension. quick head at the terminal extension. Cyclops is the post ACL reconstruction patient will have if you don't have a proper femoral notching, that notch, that intercondylar notch, if you don't remove that osteophyte, the graft is malpositioned, there is a constant rubbing of intercondylar notch on the ACL, and it leads to the fiber polypodium nodule. It will produce pain, and it will produce decrease it won't allow the full extension of the knee, and also there's some clicks. So it is a fibrous nodule of granulation tissue. The where it will occur, the sites of occurrence is classic cyclops lesion, the tibial attachment of the anterior cruciate ACL graft. The tibial attachment. Inverted cyclops lesion at the femoral side. Atypical cyclops lesion at the mid substance of the ACL graft. So classically at the site of attachment of tibial side, and the inverted cyclops lesion at the femoral side, and the atypical cyclops lesion at the mid substance of the ACL graft. The cyclops lesion where you can see in the scope, that's a fibrous nodule of granulation tissue. So this is MRI. In the sagittal cut, you can see there is a fibrous nodule of cyclops lesion is present. This is the fibrous nodule. So how do you interpret Latchman or anterior drawer test? So anterior drawer test we don't usually not being done. It's slowly getting out of by fixing. People don't normally usually stop doing anterior drawer. They just do Latchman. So Latchman has two grades. Grade 1 is bony endpoint. Grade 2 is firm. Grade 3 is soft endpoint. Grade 1 is also like 5 mm displacement, anterior translation of 5 mm, 5 to 10 mm, and more than 10 mm also. So what are the intraoperative complications of ACL? So when you when you drill the femoral tunnel, when you drill the femoral tunnel close to the posterior cortex or improper femoral tunnel placement, it will cause posterior wall flow. That's a cortical breach of the posterolateral cortical wall of the lateral femoral condyle. So postoperative complications, one such very important complication is arthrophyrosis. So in acute ACL injury, the knee will always have an hematoma. It will always have an inflammation going on. So when you operate an acute ACL injury, the common complication that you can encounter is arthrophyrosis and also the release of the extravasation of the fluid. So that's why in acute patient has sustained ACL injury, you have to give him a knee brace, ice pack application. You have to wait minimally the time they say to wait is 2 to 3 weeks. So ideally we wait for 2 weeks and then we operate. Causes of failure is improper tunnel placement, and the many causes are there for graft failure, and it's improper tunnel placement and the obesity and not following the appropriate rehabilitation protocol, all those things, graft preparation, improper tunnel, inadequate fixation, choice of the graft can also influence the failure of ACL. So position of femoral tunnel, what are the kinematic sequence of the femoral tunnel position? So there is anterior and posterior. In anterior place to femoral tunnel, it is tights in flexion and slacks in extension. And posterior femoral tunnel, slacks in flexion and tightens in extension. Tibial tunnel, in the anterior place is tights in flexion and the notch impingement with extension, and posterior tights in extension and impingement with posterior cruciate ligament. These are the kinematic consequences. So vertical femoral tunnel placement and more horizontal graft plate. What happens if you place the femoral tunnel more vertical? The AP stability will be good, but there will be rotational instability. When the graft is placed more horizontal, more or like 10 o'clock for the proper anatomical position, it will also have an anteroposterior stability also will be there, and there will also be a rotational stability also will be there. Coming to femoral tunnel malposition that was shown on the last slide, the graph displays two anterior, two posterior, and all those things. It will be slacks in extension, slacks in flexion. When the graph is placed two anterior, it is tight in extension, but slacks in flexion. Sorry, tight in flexion, but slacks in extension. So this is what happens. It is slack in extension, but tight in flexion. When the graph is placed very too posterior, it is tight in extension, but slacks in flexion. This is the normal placement of the graph. You can see there is no slack or there's no tightness. It just says the I to achieve the isometric line. So the same side is being the femoral tunnel anterior posterior and tibial tunnel anterior posterior. Tibial tunnel anterior tights in flexion, posterior tights in extension. It also causes impingement in extension, also causes impingement in posterior posterior. So femoral tunnel malposition, as you can see, the two anteriorly placed tibial tunnel impingement limits extension. And two posteriorly placed tibial tunnel will cause impingement with the ACL, posterior cruciate ligament. Cause impingement in the intercondylar arch when it's placed two anterior, and it will cause impingement with ACL when it's placed two posterior. So this is arthropibrosis. There is also fibrous tissue be accumulated. There is loss of motion, knee stiffness, there is decreased range of knee motion. More with the acute ACL reconstruction. So you should ensure full range of motion and subsidence of swelling before surgery. So you give some knee brace and ensure full range of motion and subsidence swelling before surgery. And there should also be a proper tunnel placement, and you should give some aggressive cryotherapy in the post-op period. So treatment less than 3 months, aggressive physiotherapy and arthropibrosis treatment is less than 3 months, aggressive physiotherapy and continuous passive mobilization, and more than 3 months arthroscopic arthrolysis, cyclops excision. Rehabilitation protocol for ACL is bracing for 6 weeks. Patient shall be allowed a partial weight bearing if meniscus not injured. So most centers they allow full weight bearing also. It depends on the physician surgeon's protocol. So it's either partial or full weight bearing. If the meniscus been injured, we allow non-weight bearing for 6 weeks to heal, to allow time for healing of this. Range of motion is kept at full degree. First, we range of motion brace, we give full range of motion in eye supplication, partial weight bearing. Criteria for normal ACL are fiber orientation as steep or steeper than the intercondylar groove. Fibers all the way from the tibia to the femur. So tibial tunnel is placed like the landmark is native ACL remnant. We can place the tibial tunnel, or else it's 10 mm anterior to the PCL attachment. This native ACL remnant. So the diagnostic of ACL is MRI. MRI is usually will give an initial diagnosis. Arthroscopy is definite diagnosis, but initial diagnosis can be MRI. So the primary signs of a tear are discontinuity on a T2 weighted image, abnormal orientation, waving of fibers or edema or non-visualization of the fibers. Secondary sign, there will be a bony bruise. ACL tear in MRI findings in sagittal view. This is sagittal view cut. There is a discontinuity of the fibers in the T2 images. So you can see there is a discontinuity. This is the PCL. This is the ACL, and there is a wavy or discontinuity pattern. So normal ACL fibers appear steeper than the intercondylar roof, and in continuity of all fibers all the way from the tibia to femur. Abnormal orientation, that is too flat compared with the intercondylar roof or Blumensack's line. If the intercondylar roof, the ACL fibers are too flat. Should be steep. Normal orientation is steep. It is flat. This acute angle is common in chronic cases where ACL scars to the PCL. This ACL is scars to the, this is the PCL, the scars to the PCL. This acute angle is common in chronic cases. So non-restoration of ACL also one of those things. So there is associated ACL as associated injury with the PCL, MCL, and what is what on is triad? ACL, MCL, and medial meniscus. So it is associated medial meniscus injuries also it is there, associated PCL injuries as well as so ACL injuries most commonly is another test. What we do is a pivot shifting test, pivot grade 3 pivot test. When this is grade 3, there is also injury to the anterolateral ligament. This anterolateral ligament has been the talk of the town. They've been saying that it's very important in it gives some additional rotational stability, fluency, excessive internal rotation, all those things. So when there is a grade 3 pivot, we can have you should people usually do an ACL reconstruction along with the anterolateral ligament reconstruction. This is the double PCL sign. Torn meniscus below the normal PCL on sagittal view. This is the meniscus, bucket angle tear of the meniscus. This meniscus is torn and this gives a double PCL sign. Flipped medial meniscus, bucket handle fragment. So this is the PCL, this is the bucket handle tear. So double anterior horn sign in bucket handle tear. As you can see, there is a double anterior horn. So the other one is the celery stalk sign of the ACL. Celery stalk sign describes the appearance of anterior shaped ligament that has undergone mucoid degeneration, a common phenomenon. It is a low signal longitudinal fibers are separate from each other by higher signal mucinous material, stimulating the appearance of a celery. It is important to differentiate mucoid degeneration from ACL tear where there will be high signal but absent or disrupted low signal fibers. So there is a high signal, diffuse high signal, and there is there will be diffuse high signal, and there is a disrupted low signal fibers. ACL will have a low signal fibers. Giving the appearance of a celery stalk appearance. Thank you. This is about today's topic, ACL reconstruction.